Alright, so the next muscle we're going to be assessing is the peroneus longus, specifically the cuneiform division of the peroneus longus. So in order to assess this muscle, we'll have the patient supine on the table. The leg that we're assessing, we're going to kind of bring up to that 45 degrees of hip flexion, 90 degrees of knee flexion, so kind of that half calf position. This foot is going to be just off the, kind of hanging off the edge of the table. And so in order to test the cuneiform division of the peroneus longus, we're going to have the patient then fully plantar flex. So they're going to kind of keep their foot in that plantar flex position on the table. And they're also going to abduct the foot. So they're going to kind of pull that foot out into abduction, maintaining that plantar flex position. From here, I'm going to be stabilizing the base of the heel, and I'm going to sort of grab or bring my hand on that lateral aspect of the forefoot. And so my action is actually going to be into adduction of the foot while maintaining that plantar flexion. And so I want to line up, get my elbow in line so I can get true adduction. So when I say go, I'm going to have you resist me pushing your foot in. Ready, go. 1,000, 2, 1,000. If I notice any weakness in that peroneus longus, the cuneiform division, we'll go ahead and perform our DFAMAT. So we'll first start in the origin fibers, kind of on the lateral aspect of the upper 1/3 of the fibula, so that posterior lateral surface of the fib. So we'll kind of dive in underneath, find that fibular head, dive in underneath, palpate those fibers back along that posterior portion of the fibula, that upper 1/3 of the fibula. And then we'll go down distal to the base of the first met, the lateral aspect of the first met and cuneiform, and palpate those fibers where the cuneiform division inserts. Once we've done our palpations, we can go back and do our PIC contractions. And so we'll have the patient go back into that abducted plantar flex position. And so Bree, what I want you to do is just push the outside part of your hand into my hand, or your outside part of your foot into my hand at 10% effort for 6 seconds, okay? Ready, push. 1, 1,000, 2, 1,000, 3, 1,000, 4, 1,000, 5, 1,000, 6, 1,000. I would perform 6 of those contractions at holding each one for 6 seconds. All right, so next we'll be assessing the metatarsal division of the peroneus longus. So in order to assess this muscle, we'll have the patient supine on the table, back in that 45 degrees of hip flexion, 90 degrees of knee flexion. We're going to have them plantar flex their foot and then abduct their foot. And so since we're assessing the metatarsal portion, we'll actually switch our positions to where we're standing, so I can try to pull this big toe into extension or dorsiflexion. So I'm going to be stabilizing the back of the heel. When I say go, don't let me pull that toe up. Ready, go. 1, 1,000, 2, 1,000. If I notice any weakness there, I would go ahead and perform my DFAMAT, which in this case is again going back up to that posterior lateral aspect of the upper portion of the fibula. So we'll find that fibular head, dive just underneath, and palpate those fibers back through the origin. And then we'll slide distal, and we'll actually go to the plantar surface and the lateral side of the base of the first met. So the lateral aspect of the big toe, and then just underneath that plantar surface as well. And we'll perform our DFAMAT on those areas. And then we can also go into that the lateral side of the first cuneiform as well. So we'll palpate that first cuneiform and palpate those fibers there. Once we've done our DFAMAT, we'll go back and do our PICs. So back into that same position, 45, 90, and we're going to have them plantar flex, abduct, and stabilize. I want you to just, with 10% effort, push your big toe down into my hand. 1, 1,000, 2, 1,000, 3, 1,000, 4, 1,000, 5, 1,000, 6, 1,000. We will perform 6 of those contractions, holding each one for 6 seconds. All right, so the next muscle we'll be assessing is the lateral division of the peroneus brevis muscle. So in order to assess this muscle, we'll have the patient laying supine on the table in that 45 degrees of hip flexion, 90 degrees of knee flexion position. We'll be at the base of the client or the patient, and basically they're going to be in a plantar flexed position, as well as slight abduction of the foot, just a little bit. There's not too much as when compared to the peroneus longus. And so we'll stabilize the heel. I'll come into that lateral side of the foot, and I'm going to be pushing straight into adduction as they resist. When I say go, resist, ready, go. 1, 1,000, 2, 1,000. If I notice any weakness there, we'll go ahead and perform our DFAMAT. So this is going to be that middle 1/3 of the lateral aspect of the fib. So we'll kind of palpate that middle portion of the fibula right on the outside, right in that peroneus brevis. And then we'll slide down distal to the base of the 5th mat, that plantar surface of the 5th mat where that tendon inserts on the bottom of the foot. And we'll perform our palpations there around that 5th mat, and then we'll bring, staying in that 45-90 position, we'll hit our PIC contraction, so we'll have the patient plantar flex and slightly adducted. Again, we're making sure that we're not extending the toes, so you can see her toes are in a nice neutral position. So from here, we'll stabilize the heel, come into the lateral side of the foot, and they're going to basically be pushing at 10% effort, the outside part of their foot into my hand. When I say go, ready, push out, and push. 1, 1,000, 2, 1,000, 3, 1,000, 4, 1,000, 5, 1,000, 6, 1,000. We would perform 6 of those contractions, holding each one for 6 seconds. All right, next we're going to be assessing the posterior division of the peroneus brevis. And so in order to assess this muscle, we'll have the patient supine on the table, hip at about 45 degrees of flexion, knee at 90 degrees of flexion. Patient's going to be in a plantar flex position and slight abduction. From there, I'll reach around, stabilize the base of the heel, and then I'll come into that lateral aspect of the foot. And my force is I'm going to be trying to push the patient into adduction and inversion of their foot while they resist. So resist this movement. When I say go, ready, go. 1, 1,000, 2, 1,000. If I notice any weakness there, we'll go ahead and perform our DFAMAT. So we'll hit that middle 1/3 of the lateral aspect of the fibula. And then we'll slide down to that tuberosity at the base of the 5th metatarsal and palpate those fibers down there. Once our DFAMAT is completed, we'll go and perform our PIC contraction. So we'll bring them into that plantar flex, slightly abducted position. So I want you to think of taking your foot and bringing it up and out as you're pushing it into my hand. So you're pushing out and up with your foot into my hand. Ready, 10% effort, ready, go. 1, 1,000, 2, 1,000, 3, 1,000, 4, 1,000, 5, 1,000, 6, 1,000. We perform 6 of those contractions, holding each one for 6 seconds. All right, so the next muscle we're going to be doing are the fibular division of the peroneus tertius. And so what we're going to have the patient do is they're going into the supine position on the table. We're going to bring them up to that half calf position, so 45 degrees of hip flexion, 90 degrees of knee flexion. And from here, we're going to bring them into full dorsiflexion of the ankle, full eversion of the ankle, and then they're actually going to curl their toes while maintaining that dorsiflex position. I'm going to stabilize the base of the heel, and I'm going to be pushing them straight down into plantar flexion while they resist. When I push, resist for 2 seconds. Ready, push back, 1, 1,000, 2, 1,000. If I notice any weakness there, I'll go ahead and perform the DFAMAT, which in this case is going to be that inferior or that sort of distal portion of the lateral portion of the fibula. So I'll palpate those fibers, that fibular division of peroneus tertius, and then I'll slide distal down into the dorsal medial aspect of the base of the 5th met. So top part of the foot and kind of the medial side of it. So we'll palpate those fibers down there. Once I've performed the DFAMAT, we'll go ahead and perform our PIC contraction. So we're going to come back up to that half calf position. So we're going to go into full dorsiflexion, eversion, curls, toes curled, easy for me to say. And all I want you to do is just with your foot, give me about a 10% push into my hand. Ready, push, 1, 1,000, 2, 1,000, 3, 1,000, 4, 1,000, 5, 1,000, 6, 1,000. We would perform 6 of those contractions, holding each one for 6 seconds. All right, so the next muscle we're going to be doing is the tibial division of the posterior tibialis. We'll have the patient in the supine position into that half calf position, so they're 45 degrees of hip flexion, 90 degrees of knee flexion. they're going to be fully plantar flexed in this case, and they're going to come into full adduction of the foot and the ankle, maintaining that plantar flexed position. I'm going to stabilize the base of the heel. My action is straight into abduction while maintaining that plantar flexed position. When I say go, resist, ready, go. 1 1000, 2 1000. If I notice any weakness there, I'll go ahead and perform the DFAMAT protocol, which for the tibial division of the posterior tib is going to be the sort of backside of the tibia at the superior 1/3 of the tib. So we'll palpate those fibers, and then we'll go into the sort of interosseous membrane on that medial side of the fibula. Palpate those fibers there, and then we'll slide distal down into the plantar surface of the navicular bone. So I'll palpate the navicular bone on the inside of her medial longitudinal arch, and we'll palpate those fibers at the insertion point. Once our DFAMAT is completed, we'll go and perform our PICs. So 45, 90, full plantar flexion, full adduction, and I want you to just push the inside part of your foot into my hand at 10% effort. Ready, go. 1 1000, 2 1000, 3 1000, 4 1000, 5 1000, 6 1000. We perform 6 of those contractions at 6 seconds. All right, so now we'll be checking the fibular division of the posterior tibialis. So we'll have the patient supine, 45 degrees of hip flexion, 90 degrees of knee flexion. To check the fibular division, we'll actually have them come into full plantar flexion, full adduction, and full inversion of the foot and the ankle. And so my stabilizing hand will go to the base of the heel. My action hit will come into that inside part of their foot, and I'm trying to push them into abduction while they maintain that plantar flexion and inversion. When I say go, resist, ready, hold. 1 1000, 2 1000. If I notice any weakness, I'll go ahead and perform my DFAMAT, which in this case is that posterior shaft of the superior 1/3 of the tib. And then in that interosseous membrane in between the fib and tib. And then we'll slide down to the insertion point, which in this case is the navicular bone. So we'll pop out the navicular and that sort of medial inferior portion of the navicular. Once we're done with our DFAMAT, we'll go ahead and perform our PIC contraction. So we're going to have the patient come back into full plantar flexion, inversion, and adduction of their foot and ankle. And I just want you to push the inside part of your foot into my hand for 6 seconds at 10% effort. Ready, push. 1 1000, 2 1000, 3 1000, 4 1000, 5 1000, 6 1000. We perform 6 of those contractions, holding each one for 6 seconds. We'll be checking now the anterior tibialis, specifically the tibial division of the anterior tibialis. In order to assess this muscle, we'll have the patient supine. Their hip's going to be at 45 degrees of flexion, and their knee's going to be at 90 degrees of flexion. We're going to have them go into full dorsiflexion, inversion, and adduction of their foot and their ankle, and they're going to curl their toes. I'll be standing stabilizing the base of the heel, trying to push this foot down into plantar flexion as they resist. Ready, go. 1 1000, 2 1000. If I notice any weakness there, I'll palpate the insertional fibers up just medial to that lateral femoral condyle, fibular head area, into the origin fibers of the anterior tib. And then I will palpate distal to the plantar surface at the base of the first met, where the anterior tib tendon inserts onto the bone. We'll have them come back into dorsiflexion, inversion, adduction, curling the toes, and you're going to push your foot into my hand at 10% effort for 6 seconds. Ready, push. 1 1000, 2 1000, 3 1000, 4 1000, 5 1000, 6 1000. We perform 6 of those at 6 seconds. So the next muscle we'll be doing is the interossei division of the anterior tibialis. In order to assess this, we'll have the patient supine on the table. They'll be at 45 degrees of hip flexion, 90 degrees of knee flexion. They're going to fully dorsiflex their foot and ankle. They're going to invert and then curl their toes. I'm going to be stabilizing at the base of the heel, pushing or trying to push them down into plantar flexion. When I say push, or when I say go and try to push, you resist. Ready, go. 1 1000, 2 1000. If I notice any weakness there, we'll go ahead and palpate at the origin, which is that sort of medial aspect of the fibula, right in between the peroneal Then I will slide distal down into the base of the first met, that medial surface, and then that down to that plantar surface of the base of the first met. Once my palpations are completed, I'll have them come back into dorsiflexion, inversion, curling their toes. I want you to push your hand into your foot into my hand for 6 seconds at 10% effort. Ready, push. 1 1000, 2 1000, 3 1000, 4 1000, 5 1000, 6 1000. We perform 6 of those contractions, holding each one for 6 seconds.